Good morning, students. Welcome to today's lecture. Last week we had discussed the risk factors of oral squamous cell carcinoma and the etiopathogenesis of oral squamous cell carcinoma. This is the third segment of our topic, oral epithelial tumors. So the learning outcomes for this topic include: we should be able to describe in detail the clinical presentation and histopathological aspects of oral squamous cell carcinoma. We should also be able to recognize the importance of early diagnosis in oral premalignancy and oral squamous cell carcinoma and apply the knowledge in thorough screening of high-risk patients. The World Health Organization has estimated nearly 657,000 new cases of oral cancers each year and more than 330,000 deaths associated with it. The burden of oral cancer is particularly high in South Central Asia. The WHO also goes on to highlight the importance of early diagnosis in the effective management of oral cancer. This brings us to the million-dollar question. How do I know if it's oral cancer? There are a number of warning signs and symptoms associated with oral cancer. We as dental professionals should be able to identify these signs and symptoms and evaluate the patient clinically and reach a diagnosis. Generally, the patients with oral cancer will present with a history of an ulcer which has not healed for over 2 weeks. The patient might suggest of a persistent growth which has been present within the mouth and there is no explained cause for it. Patient may also complain of spontaneous bleeding from the mouth. Sometimes the patient complains of numbness and pain. Patients may also complain of mobility of the tooth and difficulty in movement of jaw and the tongue. Other symptoms associated with oral cancer include pain and difficulty in swallowing, which we commonly know as dysphagia, or a recent hoarseness of voice or difficulty in talking. It should be noted here that most of the cases of oral cancer are associated with a history of tobacco use. So, does this mean it is cancer? No, it is not just enough to rely on the clinical signs and symptoms given by the patients. We have to thoroughly evaluate the oral lesion before arriving at a diagnosis. Cases of oral squamous cell carcinoma have a varied presentation. Early lesions of oral cancer can present as a white patch, a small exophytic growth, red erythematous areas, small indolent ulcers or erythroplakia. Pain is seldom present. It should be noted that oral squamous cell carcinoma can present clinically as leukoplakia. As described above, the early lesions may present as any of the potentially oral malignant disorders and hence causes confusion in the proper diagnosis of the same. Advanced lesions, on the other hand, are more obvious in presentation. Such cases are generally broad-based, have a rough nodular or warty surface presenting as an exophytic mass or ulceroproliferative mass. The lesions are generally hemorrhagic or show a necrotic surface. Some lesions are deeply destructive, crater-like ulcers with raised or rolled everted edges. Advanced cases of oral squamous cell carcinoma are usually painful. Such lesions are also associated with functional disturbances such as reduced tongue mobility, impaired speech, trismus, and dysphagia. Some cases may also present with bone destruction, which would further result in mobility of teeth, paresthesia, or rarely pathological fractures. Rare of the cases show distant metastasis, that is, spread of the tumor from the primary site to a distant region or organ. It should be noted that the size of the lesion does not indicate the extent of underlying invasion. This can be assessed by imaging techniques as well as histopathological evaluation. The clinical examination of the patient of oral cancer should include proper palpation of the lesion. One of the typical signs of a lesion which is a oral cancer will show induration. Induration means the consistency of the lesion to be of hardness equivalent to an eraser. Induration is basically because of the invasion of tumor cells into the connective tissue such that it loses its normal elasticity and becomes hard. Induration is assessed by pressing the lesion with the pulp of the finger or by bimanual palpation as seen in the images. Other feature which can be assessed and which is normally associated with a case of oral cancer is fixation. Lesions which are fixed will show reduced mobility such that when tried to move with the fingers, it shows resistance. Fixation is generally because of infiltration of the tumor into the deeper tissues. Following clinical examination, a radiographic evaluation is often done. As mentioned earlier, advanced lesion tends to show bony destruction. As you can see in this image, there is loss of bone in the interdental area between 4-5 and 4-6. This mobility of tooth is sudden and unexplained. We should remember that we should rule out the obvious causes of mobility of tooth, that is periodontitis, before considering any other pathology involved in this bone loss. Advanced cases of oral cancer may also reveal pathological jaw fracture. Another significant and most important feature associated with oral cancer is lymph node involvement. This is based on the concept of lymph node metastasis. The epithelial tumors have a propensity to migrate into the lymphatic channels and travel to the regional lymph nodes. This process is known as lymph node or regional lymph node metastasis. Lymph node can be evaluated by manual palpation, wherein upon palpation the lymph nodes will be palpable, tendered, and in advanced cases fixed. However, it should be noted that not all lymph nodes which are palpable and tender are malignant. Most of the times, if a lymph node is palpable or tender, it would indicate an acute infection. However, it should also be considered that it is possible that palpable and tender lymph nodes are indicative of malignancy. Other methods of evaluation of lymph nodes include ultrasonography and fine needle aspiration cytology. This technique leads to a more definitive conclusion of presence of regional lymph node metastasis. The process involves collecting samples by aspiration from the enlarged lymph node, preparing a smear and staining it. So, if there is regional lymph node metastasis, the smear will show, in addition to the lymphocytes, the presence of tumor epithelial cells. It should be remembered that normally the lymph node will only show inflammatory cells and no epithelial cells. Based on the clinical and radiographic features, it would be highly indicative that a particular case is of oral cancer. However, the final diagnosis should be made only after taking a incisional biopsy. As we all know, this includes taking a small piece of a wedge-shaped piece of tissue from the lesion, which is further fixed and evaluated histologically for the final confirmation. It should be noted that even if brush biopsy is performed, an incisional biopsy will be required for diagnostic confirmation and staging of the lesion. Brush biopsy is an easy and acceptable technique for the patients. However, it does not give the information regarding the grading and the depth of the invasion. Hence, incisional biopsy is always mandatory before further management is decided. Once an incisional biopsy is done, the tissue under a microscope will reveal the invasion of tumor epithelial cells within the connective tissue. Some cases will show an evidence of invasion by showing a breach in the basement membrane. Some cases will show numerous islands of tumor epithelial cells showing keratin pus, as seen in the image. Such features are associated with well-differentiated oral squamous cell carcinoma. However, other cases of oral squamous cell carcinoma on histopathological evaluation may show varied appearances. Based on these varied features, the grading of oral squamous cell carcinoma is done. Histological grading is important since it helps in determining the prognosis of the case. Another concept which you should be familiar in terms of evaluating the histopathology of oral squamous cell carcinoma is the term invasive front. The invasive front means the deepest portion of the connective tissue which shows the presence of epithelial cells, tumor epithelial cells. So, if an invasive front is deeper, it means it has a lesser prognosis as compared to a lesion which shows superficial invasive front. In addition to the tumor epithelial cells, the tissue will also show the presence of chronic inflammatory cells, predominantly lymphocytes and plasma cells. The tissue also shows increased number of capillaries, which is associated with the process of neoangiogenesis. The increased capillaries within the connective tissue is to support the increased load of tumor epithelial cells. Rarely we may see an evidence of lymphatic or vascular metastasis, wherein the tumor epithelial cells would be seen infiltrating into the vascular channels or capillaries. Since we have already discussed that the tumor epithelial cells shows varied histological presentation, based on this presentation, the cases of oral squamous cell carcinoma has been further graded. We follow the broadest classification wherein the cases have been graded as grade 1, grade 2 and grade 3. Grade 1 cases or low grade cases are also known as well differentiated oral squamous cell carcinoma. Grade 2 cases are also known as moderately differentiated oral squamous cell carcinoma. Grade 3 or high grade cases are referred to as poorly differentiated carcinoma. We should remember that some grades also add a fourth grade which is referred to as anaplastic carcinoma. However, we will stick to this classification wherein we are following only 3 grades. The grading of oral squamous cell carcinoma is basically done on the basis of the following parameters. First includes the degree of differentiation of tumor cells. This means how much the tumor epithelial cells resemble its parent cell. The parent cell means the normal oral keratinocyte. So, a well differentiated tumor will show the tumor cells which show high resemblance to a keratinocytes from an oral epithelium, a normal oral epithelium. The second parameter which is indicative of a well differentiated tumor is The amount of keratinization. Keratin production is a normal feature of an oral keratinocyte. Hence, a well-differentiated oral squamous cell carcinoma will reveal high amount of keratin production. If you can see the image on the top right corner of the slide, this image depicts a case of well-differentiated squamous cell carcinoma. This image shows numerous large islands of oral epithelial cells which are surrounded by a dense chronic inflammatory cell infiltration. These islands shows the two classical features of an oral keratinocyte. Its resemblance to its parent cell by the formation of intercellular junction and its polygonal nature and the production of keratin. So the large islands are possible because of the extensive production of intercellular junctions, and the keratin production results in what we commonly refer to as keratin pearl. The island reveals concentric, darkly eosinophilic lines which are nothing but the keratin. It should be noted that the type of keratin which is produced in the tumor epithelial islands are generally parakeratinized. The image on the bottom right corner of the slides belongs to a case of moderately differentiated oral squamous cell carcinoma. If you can see that there are hardly any keratin pearls. However, the tumor epithelial cells still have some resemblance to the parent cells by the formation of smaller islands, nests or clusters. Some cells also reveal evidence of keratin production by formation of intracellular keratin. That means cases of moderately differentiated oral squamous cell carcinoma have some amount of resemblance to the normal keratinocyte. The third grade of oral squamous cell carcinoma, that is poorly differentiated oral squamous cell carcinoma, shows minimal resemblance to the parent oral keratinocyte. As you can now see in the lower bottom right corner of the slide, the image shows sheets of oral epithelial cells. The cells are spread out entirely, with some showing strand formation. The cells do not exhibit intercellular junctions and hence do not show any island formation. The keratin production is also minimal and hence we do not see any keratin pearls. Such cases of poorly differentiated oral squamous cell carcinoma are difficult to identify histologically. Sometimes we need to perform additional staining techniques such as immunohistochemistry to identify these as keratinocytes. Stains such as cytokeratins are generally employed in such immunohistochemical techniques for identification of these tumor epithelial cells as keratinocytes. Other than grading of oral squamous cell carcinoma, sometimes we find different varied presentations of the same. This gives rise to various variants of oral squamous cell carcinoma. The two common variants associated with oral squamous cell carcinoma are referred to as the basaloid squamous cell carcinoma and verrucous squamous cell carcinoma. The basaloid squamous cell carcinoma shows numerous islands of tumor epithelial cells which show a resemblance to the cells of the basal cell layer of the epithelium. It should be remembered that a typical case of oral squamous cell carcinoma will normally resemble the cells of the spinous cell layer. However, the basal cell layer have a more basophilic basaloid appearance and hence this case will show such features. Another variant of oral squamous cell carcinoma is verrucous carcinoma, which clinically shows verrucous projections. This can be correlated histopathologically based on the presence of verruciform projections. We will discuss more about verrucous carcinoma in further slides. Other variants which are associated with oral squamous cell carcinoma include the spindle cell type, papillary oral squamous cell carcinoma, adenosquamous type, acantholytic type, and cuniculatum form of oral squamous cell carcinoma. It should be remembered that histological grading and histological variants are two different concepts and do not mean the same. Histological grading includes the assessment of tumor epithelial cells based on its resemblance to parent epithelial cell, whereas histological variants shows varied presentation of the tumor features. Following histological assessment of a case of oral cancer and the diagnosis of one of the grades of oral squamous cell carcinoma, it is vital that the tumor is staged. This staging is generally done by following the TNM classification of malignant tumors. The TNM staging or the TNM classification is a globally recognized standard for classifying the extent of spread of oral cancer. The TNM staging is done to decide the treatment plan and also to determine the prognosis. The TNM staging includes three main parameters. T stands for size of the tumor. The size of the tumor is assessed clinically and radiographically. As mentioned in the previous slide, not always the size of the tumor will be same as depicted clinically. Sometimes the depth of the tumor will be more in comparison to the superficial size. So the size of the tumor is assessed and noted down. The second component of the TNM staging, that is N, stands for extent of nodal involvement. This is related to the concept of regional lymph node metastasis. The cervical group of lymph nodes are assessed for any involvement and a value is given based on the extent of this involvement. The third component is M, and it is related to the presence or absence of distant metastasis. Following the TNM staging, the cancer is classified as one of the four stages. This is a chart showing the various parameters which has to be assessed for a proper TNM staging of a lesion. So, the first component, that is T, has four substages, four subtypes. T0 when there is no evidence of tumor. However, when there is a tumor, it will have one of these four parameters. A value of T1 is given if the size of tumor is less than 2 cm in greatest dimension. A value of T2 is given if the tumor is more than 2 cm but less than 4 cm in greatest dimension. A value of T3 is given if the tumor is more than 4 cm in greatest dimension. However, it should be noted that a value of T4 will be considered if the tumor shows invasion into the underlying structures or adjacent structures irrespective of the dimension. So whenever a tumor shows extension into underlying structures like muscles, bone, etc., the tumor is considered as T4. Moving on to the second parameter, lymph nodes are also assessed based on its dimension. A value of N1 is considered if there is metastasis in a single lymph node and it is less than 3 cm in greatest dimension. A value of N2 is considered if the metastasis is involving a single ipsilateral lymph node However, the dimension is more than 3 cm but less than 6 cm in greatest dimension. N2 has 3 subcategories, which is N2A, N2B or N2C. All these have different features. So N2A will have a lesion showing metastasis in a single ipsilateral node, more than 3 but less than 6 cm in greatest dimension. N2B will show metastasis in multiple ipsilateral nodes, none greater than 6 cm in greatest dimension. N2C will show metastasis in a bilateral or contralateral lymph node, but none greater than 6 cm in other dimension. The third category, that is N3, will show metastasis in a lymph node which is greater than 6 cm in dimension. The metastasis can be on the ipsilateral side or the contralateral side. The third parameter that is M, has only 2 subheadings. A score of MO is given when there is no distant metastasis. A score of M1 is given when metastasis is present. Metastasis is generally identified the presence of a similar malignant lesion in a distant site or organ. However, further confirmatory evaluation is done on the basis of what we know as PET scan or positron emission tomography scan, which is further followed by a biopsy. Based on the values of the T, the N and the M, we further go on to do the staging of the tumor. Here is a chart which shows the different values of T, N and M, which corresponds to various stages. As a reminder, staging is done because it helps in the formulation of a proper treatment plan and it also predicts the prognosis of the case. This is a chart which is created by National Comprehensive Cancer Network, and it shows the various stages of oral squamous cell carcinoma and the recommended treatment protocols. To simply understand the treatment plan, it should be considered or it should be understood that whenever there is a tumor, it is important that each and every aspect of the tumor is excised, because if even a small segment of the tumor is retained, it might grow further and give rise to a secondary lesion. So the treatment of oral cancer includes wide surgical excision if it is affecting only the soft tissue. Examples of such wide surgical excision include partial or total glossectomy of the tongue, or a wide surgical excision from the buccal mucosa or labial mucosa. Surgical resection is the procedure which is performed when there is bone involvement. Cancers of the gingiva or the alveolar mucosa or the palate invariably results in infiltration into the bone and requires removal of the bone to prevent any recurrence. Examples of surgical resection include segmental mandibulectomy, hemimandibulectomy, total mandibulectomy, partial resection of the palate, etc. Most of the cases of oral squamous cell carcinoma shows lymph node involvement. Hence, in addition to surgical excision or resection, the cases will also include neck dissection. This procedure involves the removal of the lymph nodes which have been affected by the tumor cells. That means the lymph nodes which are positive for regional lymph node metastasis. The idea of removing these lymph nodes is the same, that is, prevention of any recurrence following treatment. Various types of neck dissection are performed, like radical neck dissection, which includes removal of all the levels of lymph nodes from one side of the neck. Selective neck dissection are generally performed when it is possible to identify the particular group of lymph nodes which have been involved. Selective lymph node dissection involves less removal of the lymph nodes from the neck. Additionally, treatment options like chemotherapy or radiotherapy may be considered depending on the anatomic location and grading of the lesion. So this concludes the clinical description and staging, histopathological description and treatment of oral squamous cell carcinoma. Moving to the next topic, which is also known as verrucous carcinoma. Verrucous carcinoma is also sometimes referred to as low-grade squamous cell carcinoma, sometimes histologically referred to as very well differentiated squamous cell carcinoma. Other synonyms include Ackermann's tumor. Verrucous carcinoma generally presents as a slow-growing, thick, white, warty plaque of heaped up tissue. As you can see in this image, there are irregular white projections on the palatal mucosa. Verrucous carcinoma is common among tobacco chewers, and hence it is sometimes also known as snuff dipper cancer. A positive association with human papilloma virus has also been established, which includes the subtypes 16 and 18. Verrucous carcinoma is commonly seen in men, particularly in the older age group. The common sites of involvement include mandibular vestibule, gingiva, and buccal mucosa. The lesion presents as diffuse, well-demarcated, painless, thick plaque with papillary or verruciform projections, as seen in the image. The lesion is generally white to pink in color. Sometimes the lesion may invade the underlying structures and become fixed. Occasionally, we will find enlarged lymph nodes, but it should be remembered that in cases of verrucous carcinoma, the enlarged lymph node is because of inflammatory changes and not due to regional lymph node metastasis. We will be able to further understand this reason following histopathological evaluation. Before we go to the histopathological evaluation, have a look at the schematic representation. The pink portion is representing the superficial layer of the epithelium. Numerous finger-like projections are seen on the surface. So a case of oral squamous or the case of verrucous carcinoma will show such hyperkeratinized verruciform projections. At the same time, the lower blue portion depicts enlarged hyperplastic rete ridges. The rete ridges in cases of verrucous carcinoma are known to invade deeply into the connective tissue. The typical presentation of verrucous carcinoma, that is presence of exophytic, that is outwards, and endophytic growth, that is inwards, can be appreciated in a slide. The rete ridges are characteristically wide with broad and pushing margins. The rete ridges will be seen extending into the deeper parts of the connective tissue. Thick parakeratin plugs will be seen filling up the clefts between the superficial surface projections. It should be noted that in verrucous carcinoma, the epithelial cells generally show normal maturation and hence the degree of cellular atypia is minimal. The connective tissue will show an intense chronic inflammatory cell infiltration. Based on these findings, it can be understood that even though the epithelium as a whole is showing infiltration into the connective tissue, there is no breach of the basement membrane and actual invasion of tumor epithelial cells into the connective tissue, but the entire epithelium projecting into the connective tissue. Since there is this absence of tumor epithelial cells in the connective tissue, there is no possibility of these tumor epithelial cells invading the or infiltrating into the lymphatic channels or vascular channels. Hence, the chances of metastasis are minimal. Treatment of verrucous carcinoma includes wide surgical excision. Neck dissection is not required, generally not required, as it does not metastasize. Prognosis is good. Okay. Now we'll look at a abstract from an article which is conducted in University of Sains, Malaysia. This article basically evaluated the awareness of oral cancer and pre-cancer among the final year medical and dental students. It was seen that only a small proportion of medical and dental students expressed confidence in the knowledge and skills in oral cancer prevention and detection. We as dental professionals have an opportunity to screen the oral cavity of our patients. Hence, we have an opportunity to identify oral cancer at an earlier stage. Research conducted on the epidemiological prevalence of oral cancer in Malaysia suggests that most of the cases of oral cancer are detected in the later stage. This pie chart shows that nearly 44.6% of cases of oral cancer are detected at stage 4, whereas only 12.1% are detected at stage 1. The findings of this study indicate that, similar to other places in the world, even in Malaysia, the cases of oral cancer are detected at later stages. Such cases would generally make the management difficult and show a poor prognosis, whereas cases detected in the earlier stage or in the stage of pre-malignancy will show a better prognosis and show less rates of morbidity and mortality. Hence, it is important to remember that early diagnosis of oral squamous cell carcinoma goes a long way in effective management of this lesion. This is an extract from an article conducted in the United States. This also shows that most of the cases are diagnosed at a later stage, but it also highlights that early diagnosis basically increases the chances of patient survival by 90%. Various latest technologies are available for early detection. This includes a photodynamic imaging technique instrument called Wellscope. The oral CDX or brush biopsy test is a minimally invasive procedure and it helps in screening or evaluating the oral mucosal cells for any atypical changes. We are aware of the oral brush biopsy test. However, we should remember that the most significant aspect of diagnosis includes proper awareness of the clinical features of oral cancer and thorough evaluation of the patients. The World Health Organization recommends the 8 steps of oral cancer screening. This means that we should take a proper history and thoroughly evaluate each and every part of the oral cavity for every patient. The chart here shows how to evaluate each of the region of the oral cavity. If we incorporate this into our regular practice, it will be possible for us to diagnose most of the cases of oral cancer at an early stage, and hence helping our patients to attain a better treatment and good prognosis. So, to conclude, oral cancer presents in a variety of ways. It just does not present as a single feature, and hence we should be aware of the various presentations which enables us to identify a case of oral cancer during our routine clinical practice. Early detection of oral squamous cell carcinoma significantly increases the patient's prognosis and survival. With this, I want to conclude today's lecture. Before we conclude our presentation, I would like to remind everyone to be alert, to stay at home and stay safe. Thank you.